So I am delighted today to welcome Dr. Becca Mullins and Dr. Sebastion Tong, who have generously agreed to talk to us about loneliness in older adults. So I'm going to briefly introduce them and then let them get started. So Dr. Tong is an associate professor at the University of Washington Department of Family Medicine and is it Family Medicine and Public Health or just Family Medicine?
Just family medicine.
Just family medicine. Okay. He got his MD at Boston, did an MPH at Harvard, practices family medicine and addiction medicine, and is also the associate director of the WWAMI PBRN network, which is Washington, Wyoming, Alaska, Montana, and Idaho. That's what WWAMI stands for, right? Okay, and Dr. Mullins is an assistant professor at University of Colorado. She got her MD and MPH at University of Kansas and then did, after residency, a research fellowship at the University of Colorado. The two of them were co-authors of a really great paper. If you haven't read it, you should, called The Role of Primary Care in the Social Isolation and Loneliness Epidemic, that was published last year in the Annals of Family Medicine. So thank you so much for joining us, and I will let you guys get started. Oh, and one other thing, if you have questions, put them in the chat. Hopefully we'll have time for questions at the end.
Thank you so much. I think we're both delighted to be here and to be able to share a bit about our work and share about how we might address loneliness and social isolation in primary care. So our objectives are to look at what health risks and comorbidities are associated with loneliness and social isolation. We're going to talk about practical tools that you can use to screen for loneliness and social isolation in primary care. And then I think really importantly, talk about what resources there are to care for loneliness and social isolation in primary care. And as Selena mentioned, we're happy to answer any questions, put them in the chat. We'll try to get to them like during the talk, but also afterwards we can verbalize them as well. Both Becca and I have no disclosures. So I wanted to start with a case example, and this is one of my patients. This is a 68-year-old Amharic speaking female who is here for follow-up, sees me often for hypertension follow-up, and presents for a routine follow-up complaining of worsening chronic wrist, shoulder, and knee pain. She was at her last visit referred to physical therapy, but like many of our patients, I think, did not go to physical therapy. She's asking for meds to help alleviate her pain. There are a number of meds on her med list for pain relief, and she's not sure which one she takes. She lives with her husband and is actually his full-time caregiver. She doesn't have any children or relatives in the area. So like this is someone that when I hear this about like being a full-time caregiver and not having close relatives is at risk for loneliness. And like it was someone I dove deeper, screened, had a conversation with. And what I realized is her husband really doesn't like to be alone. And even though he may not need 24/7 care, he really wants to be there all the time. Wants her to be there all the time. So she doesn't really have any outside contacts or ability to like interact with other people, and she feels very alone. And one of the ways I think she finds an outlet is to find medical concerns to present to the physician for, so that she can actually then leave the house for an hour for a medical visit. And that really understanding really helped, and having a good interpreter in the situation, since the patient was Amharic speaking, really helped with that situation. And I'll talk more about how we got there and other things we can do for a patient similar to this as well. My other patient, the clinic I work in now has a gentrifying area. So I have a 23-year-old English-speaking tech worker who comes in with a history of ADHD and anxiety, who's presenting to established care. He was last treated with stimulant medication for ADHD when he was in high school, but is struggling with concentration at his new job. This was someone I saw like soon after the COVID pandemic and had done part of his college experience online, and then moved to the Seattle area for work after college and didn't have any contacts. So for him as well, like there was this element of just like isolation, both like in the social isolating component and also loneliness of not knowing anyone and not having some of the wherewithal on how to make contact since he did college partially online as well. So we'll talk more about how we can address that as well. And I'll turn it over to Becca.
Thank you. So I apologize that I am going to move through some of these kind of next setting the stage slides relatively quickly because I am making the assumption that a lot of you here are going to be on the same page about buying in to caring about loneliness and social isolation, given we're part of a culture of family medicine and understanding how important these issues are. But just in case, I did want to set the stage a little bit with the recognition of this very important health advisory released in 2023 by the former U.S. Surgeon General, Dr. Vivek Murthy, that a lot of our talk, particularly when Dr. Tong later speaks about kind of what can we do from here and how can we intervene on loneliness and isolation from a healthcare perspective, is really kind of centralized around and framed around. But, there's 50 plus years of research that illustrates the importance of loneliness and social isolation from a perspective of the negative health impacts that these two concepts have. And this health advisory really better highlighted that these are public health emergencies, if you will, that they're impacting enough people in the United States and they have such profound health consequences that every health sector, including healthcare, needs to put forth more effort towards understanding how we can be addressing them. And so kind of, again, hopefully we're all already buying into this, but this is a really, really great piece and it's a very easy read and I highly advise everyone to take a look at this. Next slide. Oh, can I change the slides? Okay. And before I move on to the prevalence and health consequences, just a quick note on definitions, because I do think it can get confusing when people use these terms very commonly interchangeably. And this is not just in the news or in public discourse. This is actually also sometimes seen in research, where you will sometimes actually see loneliness and social isolation both combined as social isolation, but they really are two distinct concepts. And it becomes much more important when we're talking about what is our role in healthcare, how can we talk to patients about it, and how might we intervene on it. But loneliness is really this subjective feeling that only you can really say if you are experiencing, because it's a distressing sense that you have a gap or deficit in your social relationships. And it's not the same thing as being shy or introverted. Social isolation, on the other hand, is objective. It's that state of being physically separated from others, so that lack of social contact or relationship. So no, in social isolation, there's nothing about how the person feels about it. It's more of an objective separation from relationships or others. And what you'll see here is we're really talking about two different aspects of lack of social connections or relationships. And we're also not really talking about, this is not the same as technically as social support or social integration, for example. These are really different concepts. Next slide. If you're more of a picture person, here you might see that on the first picture, we have loneliness. You've heard that saying, you can feel lonely in a crowd. So it's not about how many contacts are around you or your social network, how the frequency of people that you see. It's about how you feel about your relationships. Do you have the relationships that you want and that you feel distressed or upset that you don't? Versus social isolation is more about the objective number of contacts, and you're not necessarily distressed about it. That's when people sometimes say, well, like, you know, I'm a loner and it doesn't bother me. That might be social isolation. And to be clear, they're interconnected and you can definitely be both. Next slide. So does it matter to differentiate the two? Well, certainly both are very, very common. Both have profoundly negative health consequences. The reason why it matters is when we're talking about our role in the healthcare field and addressing it in primary care, the way that we're going to identify them and diagnose them, as Sebastion was just talking about in this case, the cases, and the way that we're going to potentially approach interventions or treatments will inevitably be different. Next slide. So in thinking about the prevalence of loneliness versus social isolation, it's somewhat difficult to give you an exact concrete number, particularly for loneliness, because there's an immense amount of measurement tools that are used in studies. So it really depends on which study you look at and you're referencing, which tool they've used, which population they've surveyed, etc. But I will tell you that in the 2023 U.S. Surgeon General Health Advisory, he makes the claim that more than half of U.S. adults are lonely, citing a 2018 Cigna study. So I feel comfortable continuing to cite that study, although it certainly is slightly outdated at this point. But there are, you see prevalent studies about loneliness ranging in the United States, ranging anywhere from like 15 to 70%. So, I mean, it's truly a very high range and it's very common. We're seeing more and more studies support that young adults, particularly those less than 35, are holding a high burden of loneliness and may even have the highest rates of loneliness. But older adults continue to have many known risk factors for loneliness. So what I mean by that is, even if in individual studies, if they don't have the highest prevalence of loneliness, we continue to see that the loneliness is strongly linked with risk factors that older adults are known to have a higher burden of. For example, bereavement, retirement, mobility impairment, sensory impairment, social isolation, etc. And then social isolation, on the other hand, is definitely most common in older adults, and a very common prevalence that you'll see cited is about a quarter, 24% of community dwelling older adults above the age of 65 in the United States. So these are very, very common. Next slide. I'll just quickly tell you about a study that Sebastion and I did in collaboration with Dr. John Fry, who is here. In 2017, we were the first to complete a prevalent study specifically in primary care patients. We just did a survey study in 16 of our clinics from our 2 primary care research networks in Colorado. And at the time, Sebastion was in Virginia at the Acorn PBRN. And this was in, again, 2017 to 2018, so outdated data at this point. We used the 3-item UCLA loneliness scale, which I'll tell you more about later. Next slide. We just surveyed every single adult above the age of 18 who came into their primary care clinic for any reason, and we were able to survey over 1,200 patients. This illustrates the items on the 3-item UCLA scale, which is one of the most common loneliness scale used in the US, that asks about how often someone lacks companionship, how often they feel left out, and how often you feel isolated from others. And participants answer hardly ever, sometimes, or often. And this kind of illustrates the distribution of answers. Next slide. And we found that 20% of adult patients walking into their primary care clinic for any reason were lonely at that time, which, 1 in 5 patients, we would argue, is very common, more common than many of the other diseases and diagnoses that we're seeing in primary care, including things like, particularly at that time, but diabetes, hypertension, depression, anxiety, etc. Next slide. We also notably found our study supported the trend that there was a higher prevalence or loneliness was significantly associated with younger age. And so we also found that in our primary care setting. Next slide.
I'm going to talk briefly about a follow-up study we did with just young adults in 16 practices in Washington State. So we did a cross-sectional survey where we texted individuals who had been seen within one health system in the past year for a wellness visit, who were aged 18 to 25, and the time frame was 2023 into early 2024. And what we found is about half of people were lonely in this young adult age group, so matching what previous reports are stating. And we had a response rate of about 243 patients. Not surprisingly, people who are single are more likely to be lonely compared to those who are in relationships or those who are married. Women were also more likely to be lonely compared to those who identified as male. And really, what wasn't significant, interestingly, sex wasn't significant. Gender identity was in this situation, if I'm allowed to talk about that still. And race ethnicity was not significant, nor actually the living situation, but just the relationship status. So, what was also really interesting is that even before kind of some of the recent changes, we saw that sexual gender minorities were 2 times more likely to be lonely compared to people identified as heterosexual. And that didn't matter in terms of where in the LGBTQIA spectrum one fell. I think, for example, like asexual people, all 5 of the people we surveyed were lonely. But we also saw that with bisexual, gay, lesbian, and other who identified on that spectrum. So just to highlight some of the things for young adults, I think what we're not highlighting from our research is that there's also a lot of risk factors for older adults as well, and specific risk factors for people who may be beginning to live alone, right? Because of being widowed or being isolated because of job changes or living situation changes or just life circumstance changes. So those are all factors as well.
Transitioning over to the health consequences of both loneliness and social isolation. Next slide. We'll first present to you a general framework of how social connection or disconnection leads to health or poor health outcomes. And this particular framework has been put together by Dr. Julianne Holt-Lundstad, who is a phenomenal researcher in this field. And you can really see that we have a significant amount of data already to point to a variety of different mechanisms that really make the connection between how social connection leads to our health, and also the reverse is true. This is showing kind of the positive relationship, but we also have data to illustrate how loneliness or social isolation can lead to increased stress hormone, for example, increased inflammation, increased stress, increased helplessness, and worsened health behaviors. So things like increased physical inactivity, increased tobacco use, increased alcohol use, etc. There's also been some data looking at increased medication inadherence in people that are lonely and social isolated, etc. So it's really thought to have multiple potential mechanisms that lead to these poor outcomes. Next slide. So the health impacts of both loneliness and social isolation really are extremely widespread. And I've broken them up into, physical, mental, and then kind of brain and cognition. Starting with the physical, and just to be clear, this is in no way, shape, or form kind of an extensive list here. There's just only so much room on the slide and only so much time to really discuss in detail. But here are just some of the highest hitting negative health outcomes that both loneliness and social isolation, independently of each other, have been associated with. That includes stroke, cardiovascular disease, hypertension, type 2 diabetes, poor sleep quality, physical inactivity, worsened physical function, and more. Next slide. One of the research areas that I'm currently extremely interested in and actively applying for more funding in is this link between loneliness and social isolation and cognition. And this is of particular interest in the Alzheimer's disease world, where, as we all know, there's really not a cure. And so we're having an increased focus on how can we go further upstream and try to really focus on decreasing rate of cognitive decline, or even better, reducing risk of Alzheimer's disease and dementia. And we see that loneliness and social isolation are significant risk factors for poor cognitive health. They are independently associated with increased risk of faster cognitive decline, overall worse memory and executive function, the development of mild cognitive impairment and dementia and Alzheimer's disease. Chronic social isolation and loneliness can actually increase the risk of developing dementia by 50% in older adults. And in 2024, The Lancet came out with a paper that basically stated that if social isolation and loneliness were eliminated, 5% of dementia cases could be completely eliminated as well. So this is a very hot topic in the kind of dementia cognitive impairment world. Next slide. And then, of course, mental health. Loneliness and social isolation independently increase the risk of depression and anxiety, suicidal thoughts, decreased quality of life, and deaths of despair, meaning deaths related to alcohol use, drug overdose, suicide, etc. And many of these relationships that I've just described are bi-directional, as you can imagine, and thinking back to the mechanisms. You could imagine that, depression and anxiety and the relationship with loneliness and social isolation increase the risk of depression and anxiety, and that can also be bi-directional as well. Next slide. The most convincing data that we have to say, wow, we need to act on this, and there is a significant role in the healthcare field to say these are really medical issues that we need to figure out how to be addressed in our comprehensive standard medical care, are the impacts of loneliness and social isolation on our lifespan. So loneliness is known to increase the risk for early death or mortality by 26%, again, independent of other comorbidities and genetic risk factors and social isolation. Social isolation increases the risk for early death by 29%. And something that is commonly said now for many years is that prolonged isolation is as unhealthy for us as smoking 15 cigarettes per day. So I think that this data illustrates to us something that I'm often talking to other primary care staff and physicians about, illustrates to us that these issues are actually more unhealthy for our patients, more deadly for our patients than other chronic diseases that we consider to be a no-brainer routine primary care issues, such as obesity, physical inactivity, even high cholesterol. These are actually found to be more deadly by this data. So it makes it, I think it's just very eye-opening and makes it even that much more heightening and kind of surprising and really enlightening that we need to be figuring out how to address it in primary care and talking about what is our role. Next slide. Which leads me into screening tools for loneliness and isolation that may be able to be implemented in our everyday primary care. So for loneliness, there's a relatively, particularly in the US, there's relatively good consensus that the two most common loneliness scales to identify loneliness and therefore diagnose it are the UCLA loneliness scale, which has a reliable and validated 3-item version, which I would argue when we're thinking about implementing in a primary care setting would be the way to go. And the De Jong-Gerveld scale, which has, again, a reliable and validated shortened 6-item version. The De Jong-Gerveld scale is much more common in the UK, and the UCLA loneliness scale is much more common in the US. And it really measures, I already mentioned, lacking companionship, feeling left out, or social, feeling isolated. One benefit of De Jong-Gerveld is that it includes 2 subscales of 2 different types of loneliness, emotional and social loneliness, which is really feeling like you lack a social group, a larger social group, versus lacking that social loneliness, versus emotional is lacking, feeling lonely about lacking an intimate someone or a closer network. And then there is discussion about single item measures. There's no consensus on one validated single item measure, but an example of that I put there might be, how often do you feel lonely? Often, always, some of the time, occasionally, hardly, ever, or never. The concern about that might be that when you use the word lonely or loneliness in the actual question, is there stigma then to how people answer it? And there was a recent meta-analysis in 2023 that did illustrate a lower prevalence of chronic loneliness when you used a single item measure compared to other scales. But when we're talking about how to implement screening in primary care, we do need to balance the benefits of ease of implementation and ease of administration and interpretation with, potentially not capturing everyone. Next slide. Social isolation, on the other hand, has really no consensus on the best measures. There are an immense amount of social isolation measurement tools that capture a whole variety of the structural components of relationships. And then some of them also throw in non-structural components of relationships, like quality of social support, or even some little flares of what seem to be loneliness types of questions. But I did do some research on this recently for a manuscript that was just published that was specifically about the screening of loneliness and social isolation in primary care for older adults, and with some input from local and national experts, and really landed on these 2 as being the most pragmatic for primary care. They're both highly reliable, highly validated, and very, very widely used. The Lubin Social Network Scale has a shortened 6-item version, captures social network, social isolation, and social support. And it was derived off of the Berkman-Syme Social Network Scale, but it is more specific to older adults. And then the Berkman-Syme Social Network Index has a 4-item version that measures frequency and quality of social support, social participation, and social contact. And this was actually in 2014, the Institute of Medicine Committee released a report that really said we need to start capturing measures of social relationships in our EHR. And it recommended this measurement tool all the way back in 2014. And so people have been talking about incorporating this in primary care, or in healthcare, I should say, for a long time. Next slide. So what might this look like in primary care? I would argue, let's think a lot about the PHQ-9. I think we already have the architecture, the processes and workflows built out. And again, this is even more prevalent than depression, and even more deadly, has even higher health consequences. And Sebastion is going to finish us off with, what do we do about it? Is it modifiable? And yes, we won't leave you hanging on that. So I think if we're going to think about really leveraging workflows and processes that we have already in place in primary care. We would use the screening tools to identify loneliness and social isolation in the same way. So there would be universal screening at predetermined intervals, like annual exams. And then just like Sebastion said, more targeted screening for high-risk individuals that stand out as having, something comes out that makes them seem more of higher risk to potentially have loneliness or social isolation. And again, a lot of those risk factors listed there do really impact older adults. And then if positive, there's, again, Sebastion will go into more detail about specific types of intervention, but big picture, the guidance that I've been talking to primary care providers about and really outlined in this manuscript is that first and foremost, it is an intervention to provide education on the negative impacts of loneliness and social isolation. I think that education alone and telling someone you have loneliness and you are isolated, here's why it matters, here's why I care, is doing something. And I would argue that should empower clinicians to, I think a lot of clinicians are very worried to get involved in this because they feel paralyzed about not having access to resources or referrals. But I do think education alone can really empower patients themselves to think about what might be helpful for their own lives. And then clinicians should, when identified, perform a more in-depth assessment about the individual's loneliness and social isolation, particularly looking for any contributors that they might be able to address. For example, I'm thinking about a case that I had where someone was not able to go out to their classic social activities because their diabetes had become so uncontrolled that they were feeling very uncomfortable with leaving the house without their insulin and checking their blood sugar, etc. So if I really helped with their diabetes management and their self-efficacy of managing their diabetes, I could therefore down the line also help with their social engagement. And let us not forget our other very, very valuable team members, which Sebastion will talk more about as well, but our case or care managers, our social workers, and obviously our behavioral health folks, which are an intervention within themselves, but they can also help perform this further in-depth assessment and then tailor the response based on what they learn as well, and then offer tailored referrals and response. Next slide. And I will just end with this example screening practice in clinical settings. Again, this is exactly what we're doing with the PHQ 2/9 universal social isolation and loneliness screening. This is a copy from the manuscript that was just published, where we propose that you might administer the UCLA 3-item loneliness scale and the Lovin social network scale, the 6-item, to every older adult at annual Medicare wellness visits. The medical assistant, these scales, just like the PHQ-9, are able to be completed by a patient alone, could have someone else administer them, could be completed on paper, could be completed on a computer, could be built into the EHR, and I would recommend that happen for tracking and monitoring purposes, etc. And then there's a process where if screened positive, the clinician is alerted, and then the clinician follow up with education, assessment, and response. Next slide.
So I'll talk. So now that you found out that your patients are lonely, right? And the health consequences of that, and then you screened potentially. I'll talk a bit about some of the potential interventions. I think it's a challenging area in the U.S. healthcare system because we don't have medications for loneliness, right? So there's no magic bullet that patients come in looking for. It's a lot of how do we help them psychosocially? How do we look at the context with which they experience loneliness or isolation? So this kind of connection, 6 pillars, came from the U.S. Surgeon General's office, from the previous Surgeon General, Dr. Vivek Murthy. And he actually also wrote a book talking about how he himself experienced loneliness after his first term as Surgeon General before a second term. And so some of the things are mostly beyond the scope of the healthcare system, but I think it like at least is important for us to think about like how do we think about our social infrastructure in local communities? How do we have policies that promote connection? How do we think about our use of social media, deepen knowledge? How do we build a culture of connection in our clinics and our communities? And then I think what I'll focus on is number three, which is mobilizing the health sector and training healthcare providers, which is part of what we're doing today, right? So, and then how do we think about assessing and supporting patients and connecting, doing like clinical community linkages to help address this. So this also comes from Holt Lundstedt and also was published in that report on loneliness, thinking about where do we target loneliness? So I think there's the structure of connection. So it's the number and variety of interactions that people have. There's the function, right? Like, so different relationships serve different functions. So like our relationships at work are very different from our relationships with our partner, or with our parents, with our neighbors, etc. Right? Like they all serve different relationships, right? And purposes. And then thinking about quality as well. Like, are they people we just say hi to and wave to? Are they people you actually have an in-depth conversation with? Like, how satisfied are you with those relationships? And also recognizing that some people are more introverted. Are those relationships straining for you? And are they potentially causing you more burden than benefit? So how do we balance all those different things? So even back in 2011, there was some attention to loneliness. Someone called Massey published the first meta-analysis looking at loneliness. And basically, the interventions that were studied were around improving social skills, enhancing social support, increasing opportunities for social contact, and then addressing maladaptive social cognition. And they found that the last one, addressing the maladaptive social cognition, was actually the most beneficial in terms of the studies that had looked at that area. So I'll share two studies we've done looking at how to address the maladaptive social cognition, and then also helping improve social skills and increasing opportunities for social support. And then suppose we're sharing like how can we apply this in our day-to-day practice if there is no study support, if there is no behavioral health support. So we took two different interventions for two different populations and applied them for both. One was looking at cognitive behavioral therapy, which I know when you're in med school, that's always the right answer if it's a multiple choice question, right? So like we did that because it works for loneliness, and we adapted it specifically for loneliness, looking at a program created by Swedish researchers and focused really on behavioral activation and addressing kind of the thought patterns around being alone. So really addressing the loneliness component. And then we also took a look at something called social prescribing, which is a growing movement towards. It started in the UK as a model where healthcare providers, primary care providers were able to refer to someone called a link worker who then helped connect patients to community resources. But we did this in a group format. So for our adapted social prescribing intervention, we took an 8-week virtual group intervention, and we helped people map their current activities, create a concrete connections plan, gave them examples of things they could do with spotlight activities, discussed the social connection framework, talked about how we address social anxiety, and helped them write letters to themselves to help develop concrete plans and stay active beyond the group period as well. So this mimics some of the things on the right-hand side. You see the social prescribing link worker model where they're referring people to places, looking at workplace development, creating a personalized plan of what matters to them, and looking at support groups in the community. Our CBT intervention was also virtual. I mentioned it's looking at like behaviors that are linked to loneliness, identifying values, goals, plan behaviors that are important, helping problem solve specific situations and working through thoughts, and then also maintenance was addressed as well. So we did this study and specific adaptations of this with two different populations. I think you'll do it. I think there's a study ongoing in Wisconsin about older populations. We did this actually with younger adults because we happen to get funding for younger adults. And we looked at patients 18 to 25 who screened positive for loneliness and randomly assigned them to one of two different groups, and then also collected outcomes afterwards as well. Of really interesting note in this young adult group, of the 20 people we had in our groups, we found that there was a huge prevalence of suicidality. So one of the outcomes was the PHQ-9. And when we had people fill out the baseline PHQ-9, 40% of them, or 8 out of 20, scored somewhere like scored positive on the suicide question and the PHQ-9 question. So there is a lot of high risk behavior. None of them, we assessed each of them, and none of them were actively suicidal, but some of them were were on kind of the spectrum between passive to active suicidality. So that's something really to consider as well for patients with loneliness, and if you're thinking about addressing this. What we found is that with both the CBT and social prescribing interventions, we reduced the UCLA score, not significantly, because it was a pretty small group. We had 7 scores, and we reduced PHQ-9 scores across both groups as well. More so in the CBT group, but they also had a higher baseline loneliness compared to the social prescribing group. We also did this study with patients with chronic pain. I think I'm particularly interested as a double-boarded family doc addiction medicine doc in chronic pain, chronic opioid prescribing, with the theory that people who have chronic pain may not be able to do the activities they enjoy doing. And I think that applies for multiple comorbidities, but we happen to get funding from the National Institute on Drug Abuse on this topic. So I think Becky gave the example of diabetes. You can apply that to aging, to having a cancer diagnosis, right? So I think with the chronic pain group, often social activities that may have been around active social activities may no longer be an option. So they may lose specific social groups, and they just may not be able to interact out in the outside world as well. So we took people who screened positive for loneliness, who were on at least 3 months of opioids, identified from the EHR query in 3 health systems. Of a random note on stigma, we initially labeled this as a loneliness study and said, we're screening you for loneliness. And I have never had that many complaints about a study to our IRB as I had with this study, because people are like, how did you get my information? Why do you think I'm lonely? I had someone write to the Board of Medicine in Washington State about me, and someone write directly to our hospital CEO about me, and even someone come to our clinic front desk and complain about me about the study. And so we changed our language from loneliness to, this is a study about wellness and social connection and how you interact with other people. And this is anecdotal, but all those complaints disappeared after that. So it is interesting to think about, like, what is the stigma around the word loneliness? And if we should be not using that word when we talk to patients about loneliness, right? So that was a side note and detour. So this is the ongoing study. We're looking to recruit 100 patients. We had 42 complete the intervention so far, of which the majority were white, non-Hispanic, and female. And the average age was 53, with a range from like mid-30s up to 70s. So again, we're seeing in the social prescribing group and CBT group decreases in loneliness. There was a usual care group in this case. The usual care group had some decreases in loneliness, but not to the level of the other 2 groups. We had increases on the Lubin scale. So the Lubin scale measures social connection directly. And we had increases in the social prescribing group, the CBT group, and not so much in the usual care group. And then we asked people if they were satisfied with the intervention, and people liked being in a virtual group with other people. And a lot of people attended most sessions as well. So what does this mean in primary care where we don't have these groups of interventions or research studies that are ongoing? So this is a framework that um, another researcher came up with. I think there are three overarching strategies that we should be aiming for, looking at how we promote social contact. So after someone screens positive for loneliness, talking to them about their existing relationships, having a conversation. I think this is what we do best in family medicine, like the relational aspect, talking to them about promoting social contact. I think transferring knowledge and skills to engage in social activities. How do we encourage patients to move outside their comfort zone to engage with other people? And then if there are ways in your clinic, either through motivational interviewing, small cognitive things you can do by yourself, or referring to a social worker or to a behavioral health professional in your clinic, looking at how we address cognitive and psychological barriers, so social contact as well. So I think it's really talking about a patient-centered approach to doing this. There's no like one size fits all. I think we're all trained like the basics of motivational interviewing and how do we get someone to go somewhere. How do we look at more frequent follow-up for patients who identify as lonely, given the risk factors they have, and then engaging with other clinical care team members. And if there are behavioral health professionals that can be referred to, looking at referring those patients, especially had they have comorbidities with depression, anxiety, other mental health issues as well. And then I think it's also in addressing barriers to engagement. So a lot of older adults, for example, suffer from hearing loss. So their lack of ability to hear may actually be the cause of their social isolation, right? If they don't have hearing aids to engage in things. People who don't have the appropriate eyeglass prescription, if they can't see, they obviously don't want to go somewhere, and they don't want to go somewhere because they feel unsafe in the neighborhood. I think there are other factors around safety as well that need to be addressed in neighborhoods and in communities to help people learn how to engage. And I think if there are ways we can connect with our local community centers and other community resources, then we can help patients engage with those as well, or at least set goals to doing that. I didn't actually know that John Fry was going to be on this call, but I had his paper in here talking about professional loneliness as well. So loneliness is not just in our patients, it's also in our sphere as well, in our colleagues, in our staff, and those we interact with on a day-to-day basis. In this reflection, John talked about how loneliness is resulting from the loss of the doctor's lounge, right? Like before, everyone used to run inpatient. They used to sit around and eat breakfast together and chat with other doctors and you in the doctor's lounge. Many of us only work outpatient to start with. I think I know at the beginning of COVID, this was written before COVID, at the beginning of COVID, we weren't even allowed to sit together in one provider room. How do we interact with our colleagues? How do we interact with our staff and make sure by just asking questions that they're connected and feel emotionally supported as well is also really important. Like, I don't think we're administering formal screening tools to our colleagues, but we can definitely talk to them and ask them how in the current context, how they're feeling and doing and supporting them together. So back to our two case studies. In the case of my 66-year-old female, she didn't feel like she was able to leave the house, but she had this full-time caregiving role as well, and she felt like she didn't have local people she could turn to. So I encouraged her to at least call people on the phone and talk to some relatives, friends who might not be local but further away. One very important thing for her, I think, was she used to come in to see me at the same time as her husband. I used to think, oh, that's more convenient. They only come once. But actually, for her, it was important to come for a separate visit where her husband wasn't there. So the focus was on me connecting with her the focus was her ability to get out of the house and interact with her community on the way to and from her appointment without her husband there. So that was actually really important to her. And I thought, oh, that's not patient-centered because they're not coming together, but this was an example. And I think another thing was she actually was much more talkative with the husband out there. So just being as a family doctor listening and engaging with her in conversation was really important for her. In the case with my 23-year-old with concerns for ADHD, I did engage him with behavioral health for CBT to think about like social anxiety issues, how do we address kind of cognitive thought and behavioral activation, and help do some basic concrete social planning. And then with our frequent visits, did some accountability of like, well, did you try to do the things that we said you would do? How do we think about, oh, if you didn't, what were the barriers? Not chastising, but like really trying to encourage activity and social connection between visits. And then exploring, I think, his, in this case, mental health comorbidities, like should we restart him on ADHD medications? How do we address his anxiety? And if we start ADHD medications, how do we not make the anxiety worse? So those are some examples of what things we can do. So in summary, loneliness and social isolation are really prevalent, deadly, but it's modifiable as well. Like we're seeing with interventions that loneliness does go down, social contact does go up. Given the prevalence of loneliness and the prevalence of social isolation and the way they do really affect health and mortality, I think it's really important to consider them within the context of routine medical care. And I think where else but a better setting in primary care where we're doing comprehensive care, thinking about whole person care to address loneliness through screening, through patient education, and through tailored response and referral. And I think the biggest question is being curious and asking questions of our patients and of each other and helping guide patients towards solutions, even though there's no magic medication.